Good evening, everybody. Thank you so much for coming tonight. This is the first Open Dialogue live session for the series, the Reimagine project. And so before I turn it over to the panel tonight, who you're going to learn a lot from, I'm just going to tell you a little bit about the project itself. So my name is Lori Turnbull. I'm going to be your moderator tonight. And I'm also an associate professor here at Dalhousie, and I'm the director of the School of Public Administration. So before we get going, I will tell you a little bit about this project overall. So this is an initiative of the Faculty of Management here at Dalhousie, and I think it's safe to say that about maybe 6 months ago, the Dean, Kim Brooks, and I and a number of people started to talk about how this year has gone in Nova Scotia and all that we've had to deal with. And so, like everybody else in the world, we're dealing with the pandemic. We're dealing with the public health and economic crises that are connected to that. But at the same time, we've had a very unique experience here in Nova Scotia. We have had the largest mass shooting in Canadian history. And at the same time, we are dealing with the other challenges that the rest of the world is grappling with as well. So we're thinking very heavily and very thoughtfully about the legacies of racism and colonialism and how, we need to do better. And so, like everybody else, again, in the world, we're thinking about what rebuilding in a kind of post-COVID era is going to look like. And I think the focus of this project is to take a very specific Nova Scotia approach to that. Everyone is talking about what kind of changes to the healthcare system have to occur. Everyone is talking about how to fortify the economy, how to invest, how to be able to make sure that businesses, families, individuals, institutions are able to gain strength and keep going after this. But I think the point of this project is to go a bit further and deeper than that and think about not only the economic side of the growth and the healthcare situation, but also questions about our daily lives. So how we want to live and work together, how we want to celebrate and commemorate, how we want to consume, how we want to grow together, how we want to connect with one another. And so I think a big part of this project is really taking a much larger look, a much larger lens on what building towards a future is going to look like. It's not about returning to any kind of normal. It's about getting a much greater sense of how we want to move forward. I think one thing that I should have done that I did not do yet is that I did not acknowledge that we are on the unceded territory of the Mi'kmaq. And I should have done that first, and I apologize for that. So going forward now, I'm not going to take up too much more of your time. I want to let you get to the panel. There's going to be 5 of these. Like, the way we went about the project is to try to break the overall piece down into 5 clusters, each of whom worked on a specific theme. And so I'll tell you a little bit more about the other themes later, but tonight the main theme is about caring and connecting. And so I'll introduce you to your panel very soon. But first, I'll tell you that some of the challenges that this group worked on, and they did produce a report, which they'll tell you about, but they worked on issues like the move to digital healthcare and how that works in a province that does have some challenges with respect to connectivity for many people who live in this province. They also worked on issues about like how healthcare workers are recognized and how they should be recognized. This group worked on the role of pharmacies in providing essential care. And so we're going to hear a lot of really interesting ideas from this group tonight. And so I'll tell you that the members of your panel tonight are James Barker, Raza Abidi, Lynn Yetman, and Heidi Weigand. So without any further ado, I'm going to introduce you to Jim Barker and have him come up and say some words to you.
Well, thank you very much, Lori. I really appreciate that, and I appreciate the opportunity that the project has given us to talk about how we care and connect for each other here in Nova Scotia. The pandemic, the terrible tragedies that we've experienced this year, and that growing sense that systemically, we as a people have to do better. All these points vividly illustrate our interconnectedness, our interdependence, and our interrelatedness as people. We have a felt need to care for and connect with each other. That's part of how we are as human beings. We feel that, and we talk about it a lot. You might remember a line from the recent throne speech, the line, "Canada is a place where we take care of each other." Here in Nova Scotia and the Maritimes and in Atlantic Canada, one of the elements that we have for our caring and connecting is the Atlantic bubble. And that's another thing that we've talked about a lot. And notice how we rely on the Atlantic bubble to help us care for and connect with each other. But our ability to do that, our need to do that, also has consequences. And those consequences have been powerfully driven home to us in a number of different ways, especially economic ways, as we looked just yesterday with the announcements by WestJet. So we have this need, a need in Nova Scotia, a need in Canada, a need across humanity to care for and connect with each other. It's an imperative for us, but it's something that we have to work at, and we have to be willing to make the sacrifices needed to do that. And we do it because it is that imperative. So given all that's happened to us in 2020, how do we take stock? How do we try to move forward? How do we try to care and connect as we reimagine Nova Scotia? How will we do this? How do we build back better in ways that build more resilient and more humane systems for caring and connecting? So that's what we worked on as a group. You've already had the names mentioned for some people that were on the team. Heidi Weigand from the Faculty of Management, Raza Abidi from Computer Science, and they'll be talking with us tonight. Also want to recognize Chris Hart from the Faculty of Agriculture, Ashley McDonald from the Faculty of Agriculture, and Brandy Mills from the Faculty of Management, who also worked on the project. To work the project, we interviewed a number of people from a cross-section of the healthcare sector, long-term care people, physicians, pharmacists, respiratory therapists, continuing care consultants, and members of community-based organizations. Out of those interviews and those discussions, we identified an emergent set of issues around the impacts on Nova Scotia and our ability to care and connect from each other. Out of those impacts, we also identified the consequences and how we are beginning to adapt, how we are beginning to do that process of building back better. In framing the report, as you'll look at it online, we focus on those key parts of impacts, the impacts that we've all experienced from the pandemic, from the tragedies, from that awareness that systemically we need to do better. We identified the challenges and consequences presented by those impacts, and we also talked about the potential transformations that will need to take place and how we can begin moving forward. We're going to start that conversation tonight, and we're going to start it by focusing in on three key topics from our report that represent what we've encountered and what we've worked through and what has been thrown into sharp relief by the events of 2020. First off, Raza is going to come up and he's going to talk about those underlying systemic problems and frailties that have been revealed and exacerbated by the events of 2020. Out of those systemic problems and frailties have come sets of consequences. Consequences, especially in our ability to care and connect with each other, and consequences particularly for our vulnerable populations. Heidi Weigand is going to discuss those issues. Following Heidi, Lynn Yetman is going to come and talk to us about the impact. Because out of those systemic issues and the consequences, they're profound impacts. All that has happened has had powerful impacts on our ability to care and connect, and on us as human beings, as people, as residents of the province of Nova Scotia. And that's what Lynn will address. With that, Lori, I'll turn it back to you to start off and introduce Raza.
Thank you very much, Jim. So yes, everybody please welcome Professor Raza Abidi. He is a professor in the Faculty of Computer Science here at Dalhousie and the Director of Health Informatics. So welcome.
Good evening, everybody. And I thank you for the opportunity to join this session and listen to the work that this particular team has been doing. And thanks a lot to Jim for opening the session and laying the groundwork for all of us to talk about the findings of this particular report. So as we looked into the impact of the COVID pandemic and other societal and civic disturbances that we encountered over the last 6 months, a number of systemic issues actually were noted. Now, as much as I would like to say that these were systemic issues, I should also point out that along with these issues, we also noted some very pragmatic and innovative workarounds and strategies that helped us overcome some of these issues as well. But still, we have to recognize that there are challenges that need to be looked at as we move forward and as we reimagine how Nova Scotia would look, right, and coming out of the pandemic, and how the future looks for Nova Scotians. The first issue that is quite important to look at is the access to care. Right? It is something that we take for granted, but as the pandemic hit us and we were not able to come and have a physical examination with the physicians, right, access to care became a huge issue, especially for the vulnerable population and the individuals who were living in rural areas. Now, when I say access to care, right, it is not just the physical ability of an individual to reach out to a physician or to access a healthcare facility, but it is also about the continuous care programs that are available within the community that had to be curtailed or had to be slowed down because of the pandemic. Underlying this systemic issue are two factors. Number one, there is a technical issue, which is an infrastructure, i.e. the individuals did not have the ability to reach out to the healthcare facilities that were available. And then there is an issue around the economic aspect of some of the individual communities who could not actually afford the mechanisms and the tools that were required to access care remotely. So this is an issue that we would have to revisit and look at both from a technical infrastructure standpoint and also from an economic standpoint if we want to make accessible healthcare for all of Nova Scotians. The second aspect that we looked at, and it was a systemic issue, is the healthcare workforce. Now, the pandemic actually did require a lot of fine-tuning and altering the roles and responsibilities of individuals, but this transformation was not uniform. Right? Some individuals had to do more, and some actually had to go through various retraining, which did not work very well in the initial stages, but eventually it worked out. But we have to look at the roles and responsibilities and also the remuneration aspect of the healthcare workforce if we want to reimagine our healthcare system to have a mechanism that we can provide remote healthcare, while at the same time we can provide a face-to-face or an in-person consultation with the physicians. So I think it is an issue that would come back again, because when we are back after the pandemic, then some of the mechanisms that have been implemented and applied right now, they may continue, and they are profitable and they are practical and pragmatic, but the roles and responsibilities and the remuneration aspect to it would definitely need to be reconsidered and needs a bit of a debate to equalize and to harmonize the healthcare workforce, and also to supplement it with the necessary resources that are required. The third aspect, which has a systemic implication on our healthcare system, is the IT or information technology infrastructure, what we call as digital health. Now, we were unable to have a face-to-face or an in-person consult with the physicians, the healthcare system actually transformed into a virtual care system whereby the physicians and the patients, they were able to interact over the internet. We were using various applications such as Zoom, Skype, and even phone calls were a possible medium. But we have to recognize that the healthcare system, the infrastructure, was not geared for such a transformation in such a short time. So there were various issues that came up with regards to how the physicians were actually feeling about the kind of care they were able to provide to their patients, and also how the patients were actually receiving the care that they were getting in a remote setting. The infrastructure has to be looked at, and this is the issue over here, is internet accessibility to all, especially to the individuals living in the rural areas, and access of internet connectivity to vulnerable populations is something that needs a lot of thought, and we would have to look into this. So these are just some of the three top systemic issues that I'm talking about. in this opening session. I'll be happy to talk a lot more about it when we come back for the Q&A session. And at this time, I would like to pass it on back to our moderator, Laurie, who would then allow us to continue the conversation. Thank you for your attention.
Thank you so much, Raza. That sets a great foundation for the conversation. I'm going to welcome Heidi Weigand, who is a professor in the Rowe School of Business at the Faculty of Management at Dalhousie.
Thanks very much, Laurie. Appreciate that. And also to Raza for setting up a beautiful understanding of what was happening in this particular report and this piece of work that we did. I think the way that I want to structure this is around the topic of vulnerability. And so when we look at the teasing away that word or teasing apart that word and looking at vulnerability, that becomes something that is a societal piece, not just identifying specific people that are identified as vulnerable populations. So I'm going to cover a broad spectrum of what we mean by vulnerability that surfaced in this report. The first thing that I'll identify is the workforce itself. We had so much pride, and we had so much in terms of the effort that was put in by the workforce, the frontline workers. And we recognize constantly, we're supporting as a community. These are all well received by the workforce. One of the things, though, that comes at the sort of underlying that is the issue of inequities that sometimes surface. And so let's take a look at who was the front line. Well, we have physicians and we have nurses and we have continuing care assistants as well. We have the casual workforce. We get into respiratory therapists taking a very front seat in this particular pandemic. We then look at the pharmacists who are out in the front and dispensing when sometimes the physicians had to move, who were in clinics, had to move back into a Zoom sort of mode, this virtual model. So all of a sudden we're seeing a sort of a switch. The backstage and front stage are kind of moving around. And so we look at this and we say, okay, well, who is at the front line? Well, the grocery workers are at the front line. The truck, from a transportation and delivery perspective, are at the front line. We have our healthcare workers who are working inside of these triage centers and inside of our hospitals. We also have a lot of the mental health support from the psychologists, psychiatrists, and from all of the different sort of counselors. But then we also take a look and we say, well, we have dietitians and nutritionists and a lot of different people who are playing a role in helping people to cope with what's happening at that time. And the issue becomes when we start to look at the value of the job during a pandemic and then the pay. And so one of the things that surfaced in this particular report is the fact that there is a pay discrepancy between the casual workforce and what I've called the full-time workforce or the full-time healthcare workforce. And these are things that we're going to have to work through. These are issues that present themselves in terms of somebody putting all of their effort into being at the front line, but not necessarily receiving equal pay. Or when we start to put in things like pandemic pay, are they considered? You know, our one group of pharmacists in Ontario spoke to that they were getting some form of pandemic pay, but another group of pharmacists that are working inside the hospitals were not. So these types of systemic issues that Raza was speaking to are really important to address. Another particular area that surfaced is that was dealing with vulnerable populations specifically is the issue of drug dispensing. And so if you can think about the idea that we normally would go into the pharmacy and we would get various prescriptions filled, that requires contact. So now we're switching and we're starting to move into this virtual model. We can call things in, we can have our physicians call things in. But now we also have an issue of, well, what if we can't carry our medications or we have to get them in larger bulk? Do we have that ability? What is the process for which those drugs are going to be dispensed? And something as like a methadone clinic would maybe have people that need this on a daily basis. It's quite a common occurrence when somebody is in a position, an opioid situation, and maybe they need to have somebody witness that, and that's part of their plan. Well, if we turn that into a 30-day dispensing, and we're going to give them 30 days worth of carry, that poses a problem for them, an unintended risk, but it certainly poses a problem because now they're faced with having to monitor themselves, and that maybe not be part of their initial recovery plan. So then we have something like a Suboxone, and I apologize if I had that wrong, but a drug that is injectable and can last for 30 days, an excellent solution. However, can the pharmacist in Nova Scotia be able to inject that? And if the answer is yes, and again, there are differences between different provinces, it's paid for by the federal government. So what happens when the injection happens? Well, there's a fee based with that, and that's passed on to the patient. And also, if you can't come in because there's an issue with moving into the pharmacy and exposure, well, then maybe we need to have it delivered to your physician to give it to you. Well, there's another cost with that. And the pharmacist did not want to be able to have to pass those costs on to the patients because they recognize that this is an issue. Well, now we connect the dots back to the pharmacist having extra stress, not only in workload, but in the way that their job is having to be administered. And so we don't necessarily always think of the impacts that are having to the workforce themselves, the stresses that are being put onto what I would call this front line, but that are not traditionally recognized as the front line, perhaps, in some cases. And so we need to be able to look and explore these value propositions, these inequities that surface when we're pushing, right, when we're getting the pressure to do more with shorter periods of time and less resources. Another area that surfaced was around the issue of stable home. For many of us, we went to our homes, we had our families, we're in our little bubble, and it was comfortable. But for some at risk, the idea that they would be in their home with somebody where there's potential harm for them, this became an extremely aggravated situation for them, even to the point of being dangerous. And what do we do for somebody who's at risk for being in their own home? So these surfaced as significant issues. Another area that surfaced is because of the fact that we were in the middle of these discussions with wonderful participants from the physicians, the nurses, the respiratory therapists, from local community organizations dealing with mental health, to dietitians, to long-term care facilities. One of the issues that surfaced is around the diversity in the workforce. And there was a mention on several occasions that certain populations, like, for example, it could be the Black community, it could be the Indigenous community, people of color, do not necessarily feel that they have representation in the workforce that they can identify with when they come to be served in healthcare. So this is another piece that the educators are working on. So as we look at our funnel to come into the healthcare sector, we have a number of different entry points, and we're looking at how we're going to increase the equity and diversity inclusion in this particular workforce. And then we also have a look at, where is the safety in terms of the skills. So for example, when we have to increase the workforce, we may have to open up and be able to gain resources from outside of Nova Scotia or outside of Canada who may have professional designation somewhere else, but don't here. So we loosen our policies, we loosen our regulations. Now, what happens to them when the pandemic peak has ended? Do they still continue in our workforce, or are they put back into a position where they're not included? So these types of situations where we have students coming out of schools, missing their exams, coming into the workforce, what happens to, I'll call it the 2020 cohort, right? What's going to be the case for their recognition in the workforce, the value? Is there going to be a point in time where somebody says, well, you didn't complete your exams? Are they equal? Do they get the same value as somebody who did have the opportunity to complete their education but didn't have the COVID as something that was a force that required extreme measures? The last thing I just want to mention is a recognition of the significant amounts of horrible tragedies that we've had to experience as Nova Scotians this year. And when we talk about Care and Connect, we're talking about the healthcare workforce, but really, as Nova Scotians, we are known for caring. We are known for connecting. This is our skill. This is our passion. This is what we're good at. And so as we move forward from this report, I think it's very important to remember that the community is a part of this process. And that voice of the community to make some of these changes happen is going to be a critical part. So I just want to thank you very much for this part, and I'll turn it over to Lynn Yetman back to Lori, and then Lynn Yetman from Healthy Minds is going to be able to explain her role as one of the participants in this particular adventure. Thank you.
Thank you very much for that, Heidi. So yeah, we'll just get right to the next panelist. Lynn Yetman is the Executive Director of the Healthy Minds Cooperative, and welcome, Lynn.
Thank you, Lori. I did get an opportunity to be part of some of these discussions, and it was very helpful. And from our perspective, of a mental health perspective on the issues that have been identified, we can certainly all identify that prior to COVID and the tragedies that have been happening, life in Nova Scotia for those living with mental health have been challenging before that. Issues around lack of resources in rural communities, long wait times for mental health services in our urban areas. And for those who had mental health issues or illness, it's never just that one thing. A lot of these people have other challenges facing them, such as homelessness, inadequate or unsafe housing, food security, and most importantly, what we've seen is those who lack who lack family, friends, or a sense of community, a self-created family. Those are always the individuals that are hit even harder due to having no other connections. We've identified in the mental health world that isolation and loneliness are the key contributing factors to our mental health state. And of course, with COVID and isolation and closures, that impact was felt by our mental health community. So, with cancellations of long-awaited appointments being canceled, fear that they wouldn't be able to get their medications. And then, of course, as Heidi spoke, even when they were able to get their medications, we were then, instead of getting 3 months at a time, you had to get 1 month at a time. So another financial burden when you had to pay for the subscription fee each time. Things like that would again impact on that already stressed level for many. The closing of food banks and small community settings where people would connect, homeless shelters. Those things were all big, of course, and were so much more impacted by the COVID event. And of course, you add on to that the massacre here in Nova Scotia. That on top of all the other mental health issues going on, grief has certainly made all of that even more challenging. But as communities and as has been stated, Nova Scotians are known to come together in times of great stress, and that we did. And for the nonprofit communities, we quickly came together. We certainly tried to provide programming and supports online, connecting with people. Quickly, agencies come together and put together food bags, and we're distributing them. Activity kits were being put together to send out to those who were more isolated. All of the things that we try to do to respond to that need, we put in place as quickly as possible. But again, unfortunately, those who are most vulnerable were the ones that were getting missed again, because you can only connect if you have internet. And if you have internet and you don't have a computer, you didn't have access to libraries or agencies that would allow you to come in to make those personal phone calls to connect with your physician or have some online prescription or whatever. When you don't have the infrastructure to do that, you are again even more compromised. So we've seen that quickly. Agencies got together and tried to provide cell phones. And again, we quickly realized that we weren't in a position to provide cell phones for any length of time. So they began to depend on them to connect with agencies and resources. And quickly, after 30 days, 90 days, however long these things were made for, they were then unconnected again. So again, feeling dismissed and we're trying to provide resources for a community that isn't set up to accept the kinds of resources that are needed in this new realm of reality. Reality of internet is such a big thing. I also am from a rural community, and I know in our community that it was very challenging to have consistent internet on good times, but during this time, because people were utilizing internets more and such, it would crash. You were waiting for that online doctor appointment and your internet crashed and you couldn't access it. Then you had to go back onto that wait list. So all of those frustrations and all of those things are, for those who are living with the challenges of mental health and mental health illness, these really were triggering times. I just read today a report, a stat from the Mental Health Research Canada and St. Avex about Nova Scotia actually reporting the highest levels of anxiety, depression in Canada due to COVID-19. And there was a reference made there to our state of poverty as well. So, lots for us to learn from this process, lots of learning coming possible from this report that's being talked about here tonight. And, I think efforts have been made on every level, from the healthcare, from community organizations to your neighbor, trying to meet some of those needs and be supportive. But there is a big disconnect when you are challenged financially, you're marginalized. All of those things have yet had any connection made. I just wanted to mention that before COVID, those who were marginalized were already affected and had severe challenges. COVID certainly has made that even worse. I think that as Nova Scotians, I think of the Nova Scotia Strong mandate that we heard and phrase is true. We want to be there. We want to be supportive, and eagerly looking for channels to do that. Some of the things that we heard from families, particularly families with loved ones in long-term care, was the guilt around having their loved one in long-term care when long-term care was struggling and seeing quite a few deaths happening in the environment. We talked a lot with caregivers in long-term care who felt as though felt guilt that these deaths were happening in long-term care, and almost felt like it reflected on their ability to do their job when it was much greater than that. So lots of things have left us still reeling from COVID as we're still in it. People talk of a new normal. We don't know the extent of what it has hit us quite yet, and it's still ongoing. To know about normal and even to think of recovery, and particularly recovery in a mental health perspective, we're not even close to getting there. The one thing that we have learned through this is that we are stronger than we think, and we will be more, we're very creative in finding answers. We know now more than ever that as useful and as great a tool technology has been for us, it will never replace the benefits of one-on-one in-person connection. And that connection, I love that this title of this is care and connecting, because from what we're seeing in community and particularly in mental health is the importance of connection. And when you don't have a contact, you're struggling to stay connected with any social circle that has been your method of navigating the system. And if you have no family, then you feel quickly that loss of hope. Recovery, wellness, and health are all based on hope. And, we have to find the hope in all of this to take us to the next level and bring us more to recovery. Those are just some of the thoughts that I've had and we've had here in the mental health world and in the community. A stronger connection with the system, being the hospital and the networks and community, is very much needed. some of the thoughts that my coworkers and I had come up with is as far as of things to think about as a possibilities is generally comes back to economics. It comes back to a guaranteed income, a basic income, looking at what are our basic necessities for individuals prior to this, and looking at now what do we consider as basic essentials for the individuals during COVID. So lots for us to think about. I'm looking forward to hearing some questions at the end of this. I thank you for your time and the opportunity to participate.
Thank you very much, Lynn. And I especially appreciate you joining us tonight as both a participant and as a member of the community to come in to talk with us. Also want to thank Heidi and Raza for their comments from earlier. What we've done tonight is to talk with you about how all that 2020 has thrown at us, how it has shaped and affected and shifted and moved our ability to care for and connect with each other. And as Heidi noted when she was talking, that's part of what we do. So tonight we framed up the systems such as accessible healthcare and the sustainability of the workforce that goes with that healthcare, the consequences that all these issues, those systemic problems have thrown at us, such as accentuating the vulnerabilities, not just in the healthcare workforce, but the vulnerabilities in our population as large, and as the impact of those that Lynn talked about, the grieving, the loss, the disruption, the frustration. But notice too that Lynn talked about ways that are emerging of going forward, things that we are doing to go forward better, to go forward more effectively, more usefully. That's what you're going to find in our report. In our report, we'll talk about the issues and the impacts of those issues on our ability to care and connect for each other, but you'll also find a discussion of those potential and emerging ideas, ways, adaptations that we're all doing to find new ways of moving forward. When we reflect on these issues, we have to come to a reckoning. We have to come to a candid conversation about how we should care for and connect with each other better going forward. So for that reckoning to occur, and for it to occur in a positive and in especially a useful way, we have to talk with each other. We have to have those difficult conversations about what are we going to do. And that's what the Reimagining Nova Scotia project is about. And that's what the Care and Connection piece is about. It's about starting that necessary conversation and charting a useful trajectory for us to go forward. So now we want to begin that conversation, that necessary reckoning, that public demonstration that Canada is a place where we care for and connect with each other. To do that, we need your participation. We need your questions, your engagement, and that's what we would like to invite for you right now, or invite from you right now. With that, I'll turn it back to Lori, and we'll open things up.
Thank you so much, Jim. And so, yeah, we'll bring everybody back in now so that people are able to pose questions. And I, too, want to extend my thanks to all of the panelists for such thoughtful contributions. And I want to say, too, that part of the logic of how we put this project together is that for every team, we took a kind of clustered approach where not only were there academics on the team, but there were also people from the community, experts in the community, practitioners. And so it wasn't a sort of group of people who are used to talking to each other. There were people who all had expertise in the issue that they were working on and brought their own perspective, their own vantage point, their own awareness of what's important and what needs work. And so I think that's one of the reasons why the exercise has worked so well, is because it really did kind of bring some very fresh perspectives together and see what they could create together. And so before we turn it over to the public, the questions from the audience, questions from our audience, I wanted to ask a question of my own of the panelists. And because I'm in public administration, leave it to me to ask this kind of question. But I want to pick up on a part of the report that talked about red tape and eliminating procedures. And so I think one of the things that we've seen in government responses to COVID across the country is this sort of change in how we do the public administration of services. In many cases, governments have rethought how to bring services to Canadians, how to be responsive to Canadians. And that has sometimes meant a focus on getting something out and getting the service delivered, and not so much going through all of the typical channels and procedures that we normally would. And I think that that probably in many cases has changed people's expectations when it comes to how government does its work and how services are delivered. So I'd be interested in hearing from the panelists on what was the focal point in that for you? What do you think when it comes to red tape, procedures, what can we eliminate? What can we kind of shorten and do better in the types of things that you've been talking about?
Well, I can take a stab at that one from the participants. I think is what the position I would take is when the COVID happened, and I don't think that anybody would not know this part initially, but everybody had to adapt, and so the ability for the regulators in all of the different types of roles that came into the healthcare sector to be able to figure out so quickly what they could open up and create flexibility was fantastic. Now, in some cases, that means you may not be able to think about the unintended risks that come with that, but it's about measuring, where is the necessity to loosen something, for example, bringing in and enhancing the workforce and not having necessarily the designation inside Canada, but recognizing the talent that's coming from outside Canada, from our immigrant population. I mean, that in itself has it has a benefit in the sense that we're recognizing the beautiful talent that is coming to our country. At the same time, we recognize that there are specific regulations. Where and how we tease through that and flex through that is, I think, something that Nova Scotia was very good at. And it became very evident in so many different areas. And that was a consistent story throughout all of the different discussions that we had, whether it was at a group level or individual. So I'll just kind of leave that for someone else to tease out or to talk about. But it was definitely a very strong, positive message of how Nova Scotia reacted.
I think I'd also like to add another perspective to the red tape. And I don't know whether it is a red tape issue or not, but it is definitely around certain regulations that we have with regards to information sharing. So when the system actually was becoming remote, and we were talking about physicians needing to speak with their patients in a remote setting, information sharing actually became an issue because the system was actually not set up. So I think there is some room over here because the physicians and the patients, right, they are communicating over, yes, it is an unsecure line, but it is for a good intention, right? And I don't think so that it would be a negative thought around that, is my information being shared over an unsecured network or not? Likewise, the health information system has multiple components to it. How do the physicians actually access information? Where is the medical, the pathology reports, the x-rays? These are all separate systems, and they don't necessarily talk with one another. But this time around, you needed to bring them all together because now you have a remote consult. And I think, again, at that point, there is some need for flexibility, interoperability to remove those privacy concerns to some extent, right? So that information can be used in a purposeful way. And I think it's not a red tape issue, but I think it is an issue around trust and utility of that information.
I think too, in the health field, we've seen that that COVID has also has allowed them to implement programming quickly, and the red tape of developing programs and making sure it meets certain standards and stuff. We've been working with the health authority years on an outreach program, which we've seen some pieces of that implemented very quickly in order to respond to people in community who they knew would need resources right away and not have that access. We have some really great mental health programming online now through the health authority. We're seeing the intake process connecting faster, and giving you an individual to speak to on the phone. So maybe you're still not getting in to see the psychiatrist or the psychologist, but that supportive help that you're getting while you're waiting is what we were looking for all along. And now that's being implemented because you can't get that. You can wait forever for the appointment. You're going to have a long time to meet in person again. So some of those initiatives that were kind of wrapped in red tape have been loosened enough to make pieces or parts possible that have actually been more helpful than leaving it tied up in red tape.
Lori, for me, a key element to this is getting the right people to talk with each other. And that's actually a role that government, like the province, can be a useful facilitator for. Because we just saw in the last couple of days, the physicians working on the continuation of being able to do virtual care, and seeing that has come up to the discussion that's being talked about. But some of the examples, like dealing with missed exams, or dealing with the time that a student may have needed to be in a practicum, or a time a student needed to be in a cooperative or a placement situation, how all those worked out, and making that work out well, that can be an issue that can be facilitated between a discussion with the regulatory bodies and, say, maybe NSCC or the other body that might be involved. But it's being able to get those key groups together so that we can have a discussion, so that we can decide on a point and move forward on it quickly. And again, that's actually a useful place that a government agency can play, or a useful role that they can play in facilitating that.
This is fascinating. Yeah, it sounds to me like this is a lot about just being very mindful and acknowledging what's been happening, and just making sure that we take a lot of those lessons forward. Okay, we are going to get to some questions here before we run out of time. Can I ask this question? What do you believe the role of the Nova Scotia provincial government is, either in initiating or supporting the adaptations to our response to COVID?
I would start on that one just by echoing the point about, I would urge the province to look for places where you can make something useful happen. And so if that usefulness is bringing two groups together, a regulatory body and education body, so they can work out an issue around licensing that was disruptive, that the province being able to step in and trying to facilitate those kinds of discussions, or even the regional municipalities, or wherever. It's when we know that we need to move forward, we also, in part of Caring Connecting, that is something that we look to governments to help us do, to facilitate our ability to do. That's why the issue about red tape pops up, because we know we need to move, we need to do. We need the government to embrace a facilitation role.
Yeah, I agree. And I think that we're really moving through a lot of those basic questions about what the role of the state is. And that's really a focal point in a lot of the themes in the whole Reimagine project. It is about what we want and need from the state, and what roles they can play, maybe in an innovative way that they haven't before.
And that's listening to community as well. I think that the province has made some great strides, has made some bumps, and rejigged and moved along again. And I think it's an evolving thing for all of us. But I think if we miss the community piece, if we miss involving, the communities that are serving, the nonprofits, the educational systems, all of the systems that need to come together to have a positive outcome. I think they believe they're doing the best that they can for the majority of the people, but I think they need to make that decision based on a collective of perspectives.
Absolutely.
I'll just add one more point, because the first two were wonderful. And I think there's also a need to establish a connection between social services, civil services, and healthcare services, right? Because health actually encompasses all aspects of our life. So we need to have a perspective on what were the outcomes for various programs, whether they are social service programs or healthcare programs, on the outcomes of Nova Scotians. Right? I think that data sharing and sharing of success stories, and also some analysis that is cumulative across the entire spectrum of a human life, I think that is something which the provincial government can do and establish those bridges, which probably do not exist right now.
Yeah, and I think a lot of what we're talking about here speaks to the issue that's come up a few times in the conversation, which is trust. I think that that's a key in order to kind of build that trust. I think government does have to draw on that knowledge and that expertise that comes from communities, and also what we're learning with data. That's all a big part of it. I am going to tee up another question here, and I'm going to go to Heidi for this one first. What are your thoughts relating to the phrase we've been hearing throughout the pandemic, the new normal, and the call to adapt or accept the situation of normal? This is a great question. How will the new normal serve the communities discussed in the report in terms of equity, inclusion, and accessibility?
Thanks very much, Lori. Well, I think the first thing I would address here is when we talk about the new normal, if the new normal means that we have those who are not represented sitting at the table, invited to the table, if we have those that are sitting at the table have a voice, and if we have those that have a voice, have that voice and that turned into wisdom that we use, then I think our new normal is better. And so when we think about the way that equity and diversity and inclusion and accessibility has been framed in our discussion today, we've talked about some systemic issues that are consistently being pressured even today as when we look at our society in Nova Scotia. And so the idea of dialogue and being able to be at the table and have those voices present and to be able to make sure that those voices carry and that they affect change, then I think that what we're doing in this new normal is going to be something that really changes the inequities that we identified, the systemic issues that we identified, and I think it really addresses what we are. We are a caring and we like to connect, but we need to do it better.
Thank you so much, Heidi. I'm going to wait for a question to load up here.
While we're looking for a question to load, or the next question to load, Lori, I would just follow this one with saying, because it occurred to me when I was listening to Heidi that I'd mentioned before that government can play a good facilitation role. Actually, this particular role in terms of keeping the conversation about vulnerable populations, about equity and inclusion, keeping that conversation in front of us, keeping it as a point of conversation in our foreground, that's actually a good role for the higher education authorities and the university authorities to take on. And particularly with the type of access that we have and the ability that we have to foster that kind of conversation. So it's one that we are having, but I think it's uniquely our responsibility to keep that kind of conversation going forward so that we end up acting on it in a useful way.
Thank you, Jim. That is a great point. We don't have much time left, so I'm going to jump to this question. Being able to connect virtually with healthcare providers is so important now more than ever. Do you have updates on if medical providers will still be empowered to deliver healthcare in this manner? So Raza, let me jump to you for that one.
Okay, so I think it's a wonderful question, and it's a thought-provoking question because it is demanding a re-look at how the healthcare system actually works and how healthcare delivery is being delivered now and can be improved. My understanding, speaking with the colleagues that I work with in the medical profession, is that there would be some triaging of healthcare services. Some services would remain virtual, whereas others would come back to normal, and it would be a face-to-face consult. And why I say that, speaking with the physicians, as much as they recognize that patients are able to access them remotely, right? But they want to have a face-to-face consult because they would like to see the body language of the patient. They want to see the facial expressions of the patient. That is also typically applicable to what Lynn was saying in the mental health area as well. So this physical proximity with the patient for physicians is extremely important to judge what is going on beyond just the physical symptoms that are being monitored at any given point in time. So the answer is that we would have a hybrid system where some of the facilities can be remote, right? And we are seeing them working quite well, especially when Heidi was talking about the pharmacy example, right? And the other therapists that can actually work. But my assumption is that the specialist care would come back to a face-to-face thing. Now, whether the healthcare system is providing any support, I think there's an underlying issue around the remuneration. right? Because virtual consults are still not considered to be at the same level as a physical consult. So the remuneration has to be sorted out for this to be a bit more of a practical and a more prolonged solution. The health system has adapted, and I think those linkages will still be there. But my feeling is that we would be working on a two-tiered system, a bit of a remote, but most would be in person.
I think it's also, just to build on Raza's for a moment, we talk about the unintended risks or unintended consequences of some of these practices that are put in place. If you think about it from the physician's perspective, who are not able to see the patients directly, and if they can't, through a color of a phone, image that comes in, and they can't identify the color exactly, and they feel that they haven't been able to access self-testing tools. I mean, these are significant issues for physicians who are used to being able to be in front of somebody and diagnose, in the proximity. And then what are the impacts to the physician if they feel that maybe they weren't able to service the person to the degree that they normally would? And those are going to have consequences on their mental health, their stress, because they take the Hippocratic Oath. They're there to serve, they're there to protect, they're there to care, and yet they're doing it through a computer. And that's not necessarily what they signed up to do. So just some things to think about in terms of their mental health as well.
Mm-hmm.
Yeah. We have time for one more question, and this is a fantastic question to end on. So this is from Nicole, and for any of the panelists, if another pandemic were to hit us in a few years down the road, what is one thing you would like Nova Scotia to have in place in order to be prepared?
Well, I'll start off on it. And just quickly to give time for everyone else. What we've shown and what we found when we were working on this project is that we do have a powerful ability to adapt. We saw that in some of the things that we've talked about already with the doctors being able to shift to virtual care, with the changes about licensing, with working within dispensing practices in the pharmacies. So what we need to do is to be able to very quickly latch on to what's adapting, what's working well, and to keep it going. And to know that that's what we're trying to do. We've proven in this province that we are willing to make deep, hard sacrifices to care for and connect with each other to help us all. So what we need to do to pay off for those sacrifices is to create for ourselves that ability to see useful adaptations and move forward on them.
Thank you so much to all of the panelists, Jim, Lynn, Raza, and Heidi. This has been so informative for everybody, and this has been a fantastic kickoff panel to the series. I think that the questions that we talked about tonight these are the pivotal, this is the kind of, the main work on how to respond to the public health crisis that has been presented by COVID-19. And I know that everybody has learned a lot from this panel tonight, and I appreciate so much, not only that your work tonight, but how much work you've done on the report that is going to stay with us after that, after we close tonight, and we'll be able to learn from that, continue the conversation. I know there were more questions tonight. We just ran out of time and couldn't get to them all. And so heartfelt thanks to everybody who participated tonight, and also for the team who make this whole virtual presentation thing possible, because it looks easy, but they're all working like hell back there. So thank you so much for that. Next week, we are going to have the Support and Protect panel, same time, same place. So really hoping everybody comes out for that. Thanks a lot to everybody.
Thanks a lot, Laurie, to you for hosting it, and the backstage staff. They did a wonderful job.
They did.
Thank you.
Thank you.